The lectures contained in this module are designed to introduce the fundamental concepts in chest radiographic interpretation in short 10 to 15 minute increments. Let's start with chest radiographic technique. There are over 400 million medical imaging procedures performed annually in the US, and 1/5 of those are chest radiographs. Most of you will see chest radiographs routinely in practice, and for this reason, chest radiographic interpretation is a fundamental skill for any medical practitioner. Chest radiographs come in several varieties. The AP chest radiograph is most often a portable examination and obtained on patients that are difficult or unsafe to transport to the radiology department. When possible, PA and lateral chest radiographs are preferred for ambulatory patients because of their higher quality images. We'll finish this lecture with discussion of several special views used for problem solving, radiation dose, and densities. Here's an example of an AP portable exam. The radiography unit is to the left and on wheels for ease of transport. The X-ray tube is suspended over the patient in their bed by means of a gantry arm and positioned roughly 48 inches from the digital cassette. Note the patient is in an upright seated position, but may be supine, semi-upright, or even prone. The X-ray beam traverses the patient from anterior to posterior, and the examination is described as AP for this reason. In distinction, a PA chest radiograph is performed in a dedicated radiography room with the patient standing and hugging the detector. The source of the photons is 72 inches from the detector, resulting in a more parallel X-ray beam. The beam traverses the patient from posterior to anterior and is thus described as PA. The front of the chest is pressed against the detector with the arms to the side to move the scapula off the exam. The PA is viewed as if the reader is in the position of the cassette, that is, facing the patient. The lateral exam is also performed in the standing position. The patient's arms are elevated to prevent overlap with the lung parenchyma, and the left side of the chest is against the detector. The image is viewed as if the reader is in the position of the cassette. Dual energy subtraction takes advantage of differences in the degree to which body tissues absorb low and high energy photons. This difference allows us to generate tissue selective images. Two sequential radiographs are obtained at low and standard energy, and a computer deconvolves the tissues, resulting in 3 PA images: a standard unsubtracted image, a bone-weighted image, and a soft tissue image. The total dose for this exam is only about 14% higher than a standard chest radiograph. The soft tissue windows improve evaluation of regions typically obscured by overlapping bony structures, and the bone image is useful for confirming calcification in nodules and looking for bone pathology. Look at how much easier it is to spot the nodule in the right lung apex on the soft tissue weighted image. This nodule was confirmed at subsequent chest CT and proved to be an early stage curable lung cancer. When interpreting a chest X-ray, the first step is to evaluate the quality of the image. That will be determined by your answer to 4 questions. What is the technique? Is the patient well positioned or rotated? Is the patient inspiratory or expiratory? And finally, is there an adequate exposure? Let's start with positioning. In a supine patient, abdominal contents push the diaphragm up, decreasing lung volumes, while in an upright patient, the diaphragms are pulled down by gravity, expanding the lungs. For a similar reason, it is much harder for patients to take a deep breath when seated compared to standing. With AP exams, the source of the X-rays is closer to the patient, resulting in a geometric distortion, which will be illustrated in a line diagram to follow. Longer exposure times are necessary for portable devices, and that results in more unintentional motion. And finally, there are many more wires and tubes draped over patients in the ICUs when compared with ambulatory patients in the department's dedicated chest radiography unit. In this trauma patient, the exam on your left was obtained in AP supine positioning. Note the low lung volumes, widened mediastinum, and apparent enlargement of the cardiac silhouette. On the subsequent upright PA examination in the same patient, all these structures are now normal in appearance. This line diagram illustrates the greater magnification that occurs with an AP chest radiograph obtained at 4-foot source to image distance compared with the 6-foot distance of a PA exam. Note, in addition, the cardiac magnification on an AP exam because the heart is further from the detector and therefore casts a larger shadow. Now, how can we determine if a patient is well positioned or rotated? One of the easiest ways is to look for the medial heads of the clavicles, which are anterior structures, and the spinous process, which is a posterior structure. If the spinous process projects over an imaginary point halfway between the clavicles, the exam is well centered. Here's an example of extreme rotation. Note the difference in the mediastinal contours based on positioning. RAO results in an elongated appearance of the cardiac silhouette, while the LAO position foreshortens the cardiac silhouette and unwraps the descending aorta. How does positioning impact us in the real world? Note the profound differences in the appearance of these exams, all obtained in the same ICU patient within a 24-hour period, due to supine versus upright positioning and rotation, as well as overlapping hardware. Now let's see what phase of respiration can do to the chest radiograph. This is an image of a 42-year-old woman who came into the emergency room with shortness of breath and chest pain. At first glance, the lungs look too dense, the heart looks big, and the ascending aorta is convex along the right side of the mediastinum. You might consider edema or aortic pathology. However, on further evaluation, only 4 ribs are well seen anteriorly and 8 ribs posteriorly. On deep inspiration, we expect to see 5 or 6 anterior ribs and 9 or 10 posterior ribs. So we asked the technologist to get a repeat exam in deep inspiration. 7 minutes later, we now have the image on the right. The lung density is appropriate, the cardiac silhouette is normal in size, and the aorta no longer bulges along the right mediastinal border. Good radiographic technique has prevented an unnecessary and potentially expensive workup. Finally, we need to make sure enough x-rays have penetrated the patient to give us a diagnostic image. A good exposure for a chest radiograph results in an image in which we can see the vessels in the lung parenchyma and can just barely make out the vertebral bodies through the heart. When underexposed, the mediastinum is too white, and if overexposed, the lung parenchyma is black and lacks detail. In the era of digital radiology, exposure issues are much less common. One instance in which expiratory imaging may be useful is in the detection of pneumothoraces. As the lung increases in density on expiration, the interface between the pleural air and the lung becomes more pronounced. The lateral decubitus examination is useful to evaluate for free-flowing pleural effusions, and the apical lordotic exam, as the name implies, is designed to better evaluate the lung apices. Here's the positioning for a cross-table lateral exam. The patient is in the decubitus position, and the X-ray beam is directed horizontal to the floor. On this upright PA and lateral examination, there is a medium right pleural effusion resulting in a meniscus. The black arc indicates the expected position of the right diaphragm. In this same patient, a right lateral decubitus examination demonstrates a free-flowing pleural effusion. The visceral pleural line is outlined by the dotted white line, while the lateral parietal pleural surface is illustrated by the curved black line. Between these two lines is the free-flowing pleural fluid. Because the pleural space is a potential space, fluid and air will distribute in a gravitational fashion. Fluid will layer along the dependent portion of the chest, while air will distribute in the non-dependent portion of the chest. Thus, air rises and fluid falls. Apical lordotic exams have been largely supplanted by dual energy subtraction chest radiographs and chest CT. Rarely, this projection may still be used to get a better look at the lung apices for a suspected nodule or changes of tuberculosis. Note the hidden position of the posterior right third rib behind the medial clavicle on a standard well-positioned PA chest radiograph. This rib is unobscured on an apical lordotic examination as the clavicles are lifted above the lung apices. Patients are increasingly concerned about the amount of radiation they're receiving from imaging tests. In the case of a chest radiograph, the radiation exposure is minimal. A PA and lateral chest radiograph is 0.1 millisieverts in total, comparable to a little over 1 U.S. round-trip flight from coast to coast, or 10 days of background radiation. There are 5 basic densities visible at conventional radiography. From the lowest or darkest to the highest or whitest, they are air, fat, fluid, bone, and metal. Often, all 5 densities are visible on a chest radiograph, as seen here in a patient who aspirated a dental crown into her right bronchus intermedius. At the end of this lecture, you should be able to list the types of chest radiographs, describe the difference between an AP and PA chest radiograph, know that the chest X-ray radiation dose is minimal, and identify the 5 densities that are visible on conventional radiography. Thank you.